Hi guys, my name is Sita. Welcome back to my channel. I make videos about doing housemanship in Malaysia. So quick update, I am currently in my first posting, which is surgery, and I have 5.5 weeks left. So in this video, I want to answer 5 questions that I get asked quite often, questions that I ask myself a lot. And the question I get so frequently asked is, how long was I tagging? So as I mentioned before in many videos, tagging is the time period that you're allocated at the beginning of every department to learn the ropes. Typically you tag for 2 weeks or less if you can learn the ropes faster. I tagged for 5 weeks. So I tagged for 4 weeks first, then I was sent to a district hospital where we had regular human working hours. Then I tagged for another week. So yeah, I tagged for 5 weeks, which is 35 days, almost a little bit over a month. But then including the time that I was in the district hospital and anxiety ridden because I knew that I was still tagging, it totals to 53 days. I was tagging for 53 days. It still hurts to think about it. So my second question is, how did I finally off tag? So I love this question, right? Because towards the 25-26 day mark, which is when the last video I uploaded was posted, I was really just losing all the color in my face. In general, like I was like beige paint, if that's an expression for human existence. Like that's what I was like. I was just totally out of it. And my MOs kept asking me like, why are you still tagging? I'm like, I don't know. I don't know why I'm still tagging. I had already informed the MO that was in charge of the houseman multiple times, hey, I've done all the stuff that I'm supposed to do to off tag, but no. And that went on for another 3 weeks. So that's the reason I didn't off tag. I didn't off tag because the MO that was supposed to realize that I was done with all the requirements simply didn't off tag me. And okay, in his defense, right, I must just have been so incompetent, him thinking she's a first poster and she can't do any of the things that I expect her to do. On the days that I'm working, she's underperforming. So for that reason, I'm going to make her tag until she proves that she is worth being off tag, because being off tag means I can start doing shifts at night. When you're doing the night shift, there's only 3 housemen covering the whole department, which means you need to know what to do. You need to be some level competent, you need to be able to take blood, set lines, and address emergency situations while your MOs are in the operating theater operating, which yes, they do all through the night. So the third question that I want to answer is, what are the 5 main things that I've learned in this department? I'm not particularly sure if this is relevant to just surgery, but this is what I find to be the 5 lessons or 5 things that I can carry with me proudly into my next department. Like, I know how to do this now. So the first one is obviously requesting scans. So that's one of the things that I'm quite shocked by, the fact that you don't live in a medical drama from the US where things just get done stat. You have to go by the procedure, which is filling out the form, calling the MO that's in charge of the ultrasound or CT scan that day, and pitching to them why you need the scan, what you're looking for, what's going to happen after the scan is done, because scans are limited, precious resources. And you can either get it urgent, which is the same day or the next day. You can get an early appointment within 2 weeks, or you can get a normal appointment, which can be up to a couple of months. So you need to be able to assess the severity of the condition and make your case. So I'm not going to say that I'm the best at this, because there is some component of medical knowledge that you need, but in surgical it's quite straightforward. If you have a case of someone who has an abscess, you want to know whether or not it's an abscess to proceed with incision and drainage if it's a mature or immature abscess. So yeah, that one you know that you can get pretty soon. If it's a case of obstructive jaundice for investigation, you want to know if their common bile duct is dilated or whether or not there are stones in the common bile duct causing an obstruction. And these are things that are pretty imminent. You don't want them to go into sepsis if they start having symptoms of ascending cholangitis. So these things you pick up as, I'm starting to get a feel for what are the most common cases in surgery, and I know that I can request these scans without it giving me so much anxiety that I don't get the scan requested, the patient not having gotten scanned, and therefore delaying their diagnosis and treatment. So that's one thing, requesting scans. The second thing would probably be doing discharge summaries are so underrated. You think that it's just writing on a piece of paper about all the stuff that's happened, but that's the thing. Essentially, you're writing a story about what was the journey that the patient went on in this hospital admission. Who are they? What's their name? How old are they? Their demographic, what we treated them for in the time that they were here, what their initial symptoms were, what scans and imaging and clinical examinations that we proceeded with, how we managed the disease, and how they progressed in the ward, and what our discharge plan for them. So the next doctor that receives them, should this complaint arise again, or should they go to a hospital and require some sort of history taking, they have a piece of paper that says that very clearly, this is my medical history. A kind doctor has taken their time to write this all down in a detailed and systematic manner. So that's something that I feel I really improved on. I learned how to write a discharge summary that tells the story of a patient's medical history. It is so much more important than just the discharge summary actually has chief complaint, diagnosis, imaging, operation results, intraoperative finding. Ignore all of those. Just ignore all of those. There is a template that you should follow, which possibly I will share in the future in a more detailed way. But yeah, it's about telling the story about this patient's current admission. So scans, we have discharge summary. The third thing may not seem so important, but I think I learned how to take blood, and that's quite important. Lots and lots of stuff to say about blood taking and how to set an intravenous cannula, stuff for the future. I'm just going to go right to the next one. The fourth thing that I learned was how to make a proper referral. Oh my god, this is by right the most useful skill that you can learn early on in your housemanship, because this is something you're going to have to be doing all the time. And I'm just going to cut to the chase and give you speed advice right now. If you're referring a case to any other department, start with, "Hi doctor, my name is Houseman from this department. I would like to refer a case of a 17-year-old female who we would like to refer to rule out a gynecological pathology. Patient presented with abdominal pain, and pregnancy test was negative, but we'd still like you to have a look at this patient, just in case we missed something." Always start with the reason you are referring the patient. Don't wait until the very end. Don't go to the entire history. Just start, because that's what the MO that's on the receiving end wants to hear. And then they'll ask you a bunch of questions. Of course, you can spit out all this information, but that you get good with over time. But yeah, start with the reason you're referring them the case. So that's number 4. The 5th thing that I learned is possibly, I guess 2 things, okay? 2 things. One, very relevant to surgery. The first one is the chronology, the way things go. Okay, I'll give you an example, right? So you have a patient who just did a major operation, but then they had poor GCS recovery post-extubation. So for that reason, they had prolonged intubation, and they need to have a tracheostomy inserted. And once they have a tracheostomy inserted, they'll have to change that in 2 weeks, but the hospital doesn't provide the permanent tracheostomy tube, so you have to inform the family to get the permanent tracheostomy tube, which they can get at the ENT clinic for 220 ringgit. Also, in this time, the family should you should be able to gauge their expectations based on how well the patient is doing, and they should be able to learn nursing care. And does this mean that they require oxygenation? Because usually the patient by 2 weeks should no longer need oxygenation. They should be able to be saturating under room air. And if they need a suctioning machine, if there's very purulent secretions that are coming from the patient's tracheostomy. And the last one being, how adept are they at nursing care? 2-hourly turning of the patient, rice tube feeding, can the patient tolerate orally, like all of these things, right? These are a chronology of events that don't stress out if you can't remember all of these steps, because the main thing that you need to remember in housemanship is you learn by doing. You just repeat and make mistakes and then repeat the correct version of them so many times that it becomes automatic. So when you have a patient that's been transferred who's got a tracheostomy, you need to immediately be like, when was the tracheostomy inserted? Does the family already have a tracheostomy? How are we managing their expectations? Have they learned nursing care? Is there a nursing home involved, or are they going to take the patient home? On day 14, can I inform the MOENT to come and change the trachea tube? What are the potential complications that I can anticipate from this, you know? So the chronology of events is quite important, and you need to be involved in the patient in a way that's like, just because it's a very acute case and they've got like lines hooked up to them, tubes coming out of every orifice, doesn't mean that your role as a houseman, as an early like junior doctor, is not important. There's so much you can learn, especially when it comes to communicating to the patient's family about what their expectations are, what their recovery is going to be like. Is there a potential for removing the tracheostomy in the future? And you know, quite interesting. And part 5B would be the importance of rehabilitation in surgery. Is just so, oh my god, I didn't even realize how important this was, but that's another part of chronology. You know, when they have an operation done, you always do a wound inspection on the 3rd day, and you remove the stitches on the 10th or 14th day. And from when the operation was done, when are they able to start to sit up? When are they able to start drinking fluids and eating actual food, soft diet to solid diet? What about the drain that they have inserted? When should you remove them? How do you document the drain chart? You know, always like 50 cc to 30 cc to 20 cc to 3 cc, and then you can make suggestions like, hey, the drain is actually much reduced today, maybe we should consider removing it. The patient seems well, maybe we can send them home. So that's one aspect like of post-operative care. The second one is encouraging ambulation, like referring the patient to physiotherapy to start moving, because that helps like improve their blood flow and therefore improve like wound healing. And all of these things, you read about them in the textbooks, but seeing them actually done, seeing your patient actually get better, seeing them, measuring them to get their like TED stockings, thromboembolus deterrent stockings, getting their incentive spirometer, like getting involved in their care pre and post-op is actually quite a rewarding feeling. And you realize that so many disciplines participate in the betterment of one person's pathology, and there is something quite nice about that, really. So how is my housemanship journey going so far? I'm not gonna lie, I'm struggling with motivation. I may sound really energetic right now, but that's because I just had food and I'm a bit hopped up on adrenaline. Not that I've taken any, of course, but I wake up most mornings feeling quite tired and like dreading going to work. The days are long and so much happens throughout the day. But despite the fact that I'm struggling with motivation, like it's been really hard to film, to write, to do anything, Mosquito, to do anything that's not related to work, because it's exhausting and I don't really feel like I'm making a lot of progress. Like only in the last 10 minutes when I said all of this stuff, I'm like, wow, I've actually learned quite a lot. That was quite motivating. But prior to this, I've really been struggling, and I will talk about mental health in some of my upcoming videos. Of course I will. And the last question I want to answer is, so how am I actually doing? Not gonna lie, every second or third day I cry and want to quit. But yeah, the fact that I'm just ranting about it all the time, I guess is a sign that on some level I care and I want to get better and I want to push through, even if it really, really hurts sometimes. But I really hope that this sharing was somewhat useful, helpful to you. Again, I really wish I heard more people that I was working with, seniors, housemen, MOs alike, talk a little bit more openly about the struggles that they have, because I still feel quite alone. Everybody just seems to be doing fine. Everyone seems to be taking blood and setting lines and carrying out all the plans, and I just feel a bit like a mess, you know. Even if someone says that they think I'm a functional houseman, I have a really bad case of imposter syndrome. So yeah, I really hope that this sharing has shed some light on what housemanship is like for you. If you're in surgery, let me know how it's going wherever you are doing your housemanship. Tell me how long you tagged for, and thank you so much for watching, and I'll see you in the next video. Bye.